In this presentation, we'll discuss the pleural cavities and the lungs.
The pulmonary cavities, also referred to as the pleural cavities, and the lungs themselves are lined by serous membranes called pleurae. During lung development, the lung buds grow laterally into the pleural cavities, and as they do so, they expand into a lining of mesothelium. In this illustration, the developing lung is represented by the fist. The lining that is directly adherent to the lung itself is referred to as the visceral pleura. And the lining along the walls of the pleural cavities is referred to as the parietal pleura. The space situated between these two linings is referred to as either the pleural cavity or the pleural space. Notice that at the hilum of the lung, indicated here by the stippled line, the parietal pleura is continuous with the visceral pleura. And for reference, the word hilum is simply referring to the area of the lung where structures pass in and out of the lung. Within the pleural cavity lives serous fluid, which is secreted by mesothelial cells. This fluid coats the pleural surfaces, and it functionally acts as a lubricant to allow the layers of pleura to slide smoothly over each other during respiration. In part, the surface tension created by the serous fluid is also going to provide cohesion that keeps the lungs in contact with the thoracic wall. Therefore, as the thoracic cage expands in volume, so too do the lungs. And of course, don't forget that when the diaphragm contracts, it's going to create negative pressure within the thoracic cavity, thereby drawing air into the lungs. Let's talk more about the differences between parietal and visceral pleura, specifically in regards to their innervation. Parietal pleura is innervated by general somatic afferent fibers, whereas visceral pleura is innervated by general visceral afferent fibers. This means that parietal pleura is more sensitive to pain than is visceral pleura. Pain conveyed from the parietal pleura will be transmitted through either intercostal nerves or through phrenic nerves. More specifically, the intercostal nerves will transmit pain from the costal pleura, whereas the phrenic nerves will transmit pain from both the mediastinal pleura and the diaphragmatic pleura, which lines the surface of the diaphragm. One condition that can cause pleural pain is pleuritis, also known as pleurisy. Inflammation of the pleura makes the contacting surfaces very rough, resulting in excess friction during lung movements, which can be detected on auscultation. The rubbing of the visceral pleura against the parietal pleura is known as a pleural rub. When you hear a pleural rub through a stethoscope, it sounds very similar to the compacting sound you hear when you walk on top of fresh snow. If you're interested in hearing what a pleural rub sounds like, I hope you'll check out the link located in the notes. Let me re-emphasize that pleura are composed of layers of mesothelial cells, which are responsible for secreting the serous fluid. This topic brings to mind those late-night commercials. If you or a loved one has been exposed to asbestos and has been diagnosed with mesothelioma, please call 1-800... Well, very simply, mesothelioma is a malignancy of the mesothelium, which happens to be associated with asbestos exposure.
In lab, you'll want to appreciate that the lungs do not fill the entirety of the pleural cavities. In the lower reaches of the thoracic cavity, there are recesses that accommodate lung expansion. These recesses are clinically relevant because they can become drainage gutters where pleural exudate can accumulate when the body is erect. Pus, fluid, or blood, for example, can fill these recesses. The largest of these recesses is referred to as the costodiaphragmatic recess, found between the diaphragm and the ribs, shown here. In lab, you'll actually be able to stick the entirety of your hand into this recess on both sides. That's how large it is. There's also a second, less significant recess between the mediastinum and the left lung, called the costomediastinal recess. To my knowledge, there is no real clinical significance of this particular recess, and so you should interpret that as meaning this particular structure should be relatively low on your priority list. To illustrate some of the next few points, I would like to introduce a couple of cases. Let's suppose that a man is brought by ambulance to the emergency department with a gunshot wound to his right ninth intercostal space, just posterior to the mid-axillary line. So my question to you is, which organs or structures is this bullet likely to have damaged? Well, as you can appreciate from this image, this bullet has missed the right lung. It has traveled through the thoracic wall, through the costodiaphragmatic recess, through the diaphragm, and likely would have stopped somewhere in the liver. As a reminder, the liver lives roughly in this location here. When you perform a physical exam on this patient, you find that he has no breath sounds on the right side, and so you decide to order a chest x-ray. So what do you notice about the patient's chest x-ray compared to the normal x-ray on the left? In a normal x-ray, you should be able to visualize both the right and the left costophrenic angles, shown here. These angles represent the costodiaphragmatic recesses on chest x-ray. Also recall that the right hemidiaphragm, shown here, sits higher than the left hemidiaphragm. Again, that's because the liver is pushing upward on the right hemidiaphragm. Here, visualized through the left hemidiaphragm, we see some bubbles of gas in the fundus of the stomach. Let me also remind you that air appears black on chest x-ray. So in the normal patient on the left-hand side of the screen, we see the lungs filled with air, filling the entirety of the pleural cavities on either side. So now let's turn our attention back to our patient. Notice how you can no longer visualize the right costophrenic angle. Instead, you see all of this fluid filling the costodiaphragmatic recess. This patient not only has fluid in their pleural space, but also has a collapsed lung, as outlined here. This is therefore an example of a hemothorax, in which penetrating trauma, in this case a gunshot wound, has caused blood to fill the pleural space. The loss of surface tension and loss of negative pressure within the pleural space has caused the lung to collapse. But again, the lung tissue itself was not damaged because the bullet coursed through the costodiaphragmatic recess just inferior to the lower border of the lung and missed it entirely. So the lung tissue itself is still intact and uncompromised. Now let's suppose that a patient receives a stab wound to the upper chest that has penetrated both the thoracic wall and the lung itself. The result is a tension pneumothorax, which means that air enters the thoracic cavity and it puts tension on the thoracic organs. In a tension pneumothorax, the injured tissue of the thoracic wall acts like a one-way valve. It allows air to enter into the pleural cavity, as shown here, during inspiration, but does not allow air to escape during expiration. In addition, air is also escaping from the injured lung itself, which fills the pleural cavity. So it's a double whammy. Not only is there collapse of the lung on the affected side, but also there is a building of positive pressure within the pleural cavity, which displaces the mediastinum towards the opposite side, thereby impairing cardiac output and venous return, as well as respiration in the opposite lung. As you can imagine, tension pneumothorax is an emergent condition which requires a thoracentesis in order to remove air from the pleural cavity. To remove air from the pleural cavity, a needle thoracentesis will suffice. However, to remove large volumes of fluid, blood, or pus requires a chest tube. Whether you are using a needle or a chest tube, the principles of insertion are similar. For tube thoracotomies, the skin is numbed with lidocaine over about the 6th intercostal space in roughly the mid-axillary line. With a scalpel, a horizontal skin incision is made at about the 6th intercostal space, and the target insertion is going to be at the 5th intercostal space. After the skin incision is made, A tunnel is burrowed within the superficial fascia up to the next intercostal space, which again is going to be the target space. And so with a large curved Kelly clamp, the blunt tip of the clamp is advanced through the intercostal muscles until the costal pleura is breached. Now, as you might imagine, this insertion of that Kelly clamp can be very painful for the patient. As the physician, you actually need to protect yourself because there is natural instinct for the patient to bring their arm back down to their side once they feel that pain from the insertion of that clamp. And so it's very customary to actually take the patient's wrist and restrain their wrist against the bedside above their head so that they can't come down and actually hit the physician accidentally. Now, before the chest tube is actually inserted, the physician will stick their finger into the opening they've created within the thoracic wall, and they'll feel around to ensure that there are no adhesions against the thoracic wall and to ensure that the liver has not been compromised. Now, the key anatomical point to keep in mind here is that the insertion of the tube or even a needle is done along the superior border of the inferior rib. And again, this is done solely to avoid this important neurovascular bundle which runs within the costal groove. As a reminder, this bundle entails the intercostal vein, artery, and nerve. Let me also point out that there is a collateral neurovascular bundle along the superior border of the inferior rib. Even though the illustrator here made these two bundles roughly the same size, the reality is that the collateral bundle is much, much smaller in diameter than the larger neurovascular bundle that runs in the costal groove. So in other words, it's inconsequential if this neurovascular bundle is damaged.
With the lungs positioned in their respective pleural cavities, each lung at its apex ascends above the level of the first rib. Here, for example, is the left lung, and if I draw in a stippled line, this would represent rib 1. The same would happen on the patient's right side as well. This anatomical relationship is important for central line placement. Imagine if you were trying to place a central line in the subclavian vein and miss the vein. You might end up hitting the apex of the lung, which could cause a pneumothorax in the patient. The base of the lungs are very concaved, and they're going to rest on the domes of the diaphragm. The right lung has two fissures that divide it into three lobes. There is a horizontal fissure, as shown here, and there's also an oblique fissure, of which you're only seeing a portion of it here. The horizontal fissure divides the right lung into a superior and middle lobe, while the oblique fissure divides it into a middle and inferior lobe. And the left lung has a single oblique fissure, which runs at about a 45-degree angle, separating the superior lobe of the left lung from the inferior lobe of the left lung. Near to the apex of the heart, the left lung has a characteristic cardiac notch. And at the lower boundary of this notch is a tongue-like projection which is called the lingula. It is a part of the superior lobe of the left lung. Along the mediastinal surface of the lungs is the hilum and the root of the lung. The hilum is very simply the area of the lung where structures pass to and from the lung itself. The root, however, is the composition of all those structures that are passing in and out of the lungs. And recall from an earlier slide that here at the hilum of the lung, the visceral pleura is continuous with the parietal pleura. Here's the root of the lung, and this area here we'll call the hilum. Therefore, the contents of the root of the lung itself will be comprised of the pulmonary arteries, as shown here by the X, pulmonary veins, as shown here, as well as primary and secondary bronchi, which you can see just behind the pulmonary arteries. There will also be small bronchial arteries and veins, and then there will be lymphatics and autonomic nerves as well. Of all of these structures, you will not visualize the autonomic nerves very well. You may see some lymphatics. You should be able to find a small bronchial artery. Bronchial veins are a little more challenging to find. In addition to identifying the lobes and fissures of the lung, you'll also want to identify the structures in cross-section at the root of the lung. The bronchi, for example, are very firm to the touch because of their cartilaginous rings that keep the airway patent. By way of anatomic relationships, the bronchi are always positioned posteriorly compared to the vessels. What I've just circled would be an example of the secondary bronchi. The pulmonary veins are shown here in red because recall they are carrying oxygen-rich blood from the lungs back to the heart. In general, the walls of veins are thinner than the walls of arteries, so that can be one characteristic to help you identify pulmonary veins apart from pulmonary arteries. Another feature would be that the pulmonary veins tend to be on the inferior surface of the hilum of the lung compared to the pulmonary arteries, which are positioned usually anterior and/or superior to the bronchi. And here, again, the pulmonary arteries are shown in a purple color to designate and represent the fact that they are carrying oxygen-depleted blood from the heart to the lungs for replenishment. Also remember that pulmonary arteries like to travel along the bronchial tree. In other words, they like to travel close to the bronchi. During your dissection, also be on the lookout for one or two very small bronchial arteries. These arteries supply the parenchyma of the lung itself. These arteries will rise from the descending thoracic aorta, and they're going to supply oxygen and nutrients to both the bronchial tree and the parenchyma of the lung. There are small bronchial veins, but those are even harder to find than the bronchial arteries. The bronchial veins will drain the parenchyma of the lung, and it will return that venous blood back to the azygous system of veins. Notice here that the root of the lung is encased with pleura, and so the pulmonary ligament is an inferior extension of pleura where the visceral and parietal pleura are continuous with one another. From this view, you can appreciate that the right lung is pressed against structures of the mediastinum, including the superior vena cava, the azygous vein, and even the esophagus. In fixed cadaveric lungs, you may see impressions of these vessels and structures left behind on the lungs. However, in real life, these impressions do not exist. The impressions are merely an artifact of fixation. The contents and relationships at the hilum of the left lung are the same as those of the right lung. So again, you can identify the bronchi by touching them. They will be very firm to the touch because of their tracheal rings. The pulmonary arteries tend to live anterior and even superior to the bronchi, and again, their walls will be slightly thicker than those of the pulmonary veins, which like to live towards the inferior aspect of the hilum of the lung. The only difference with the left lung is that number one, it only has two lobes, and so it only has an oblique fissure. And secondly, it has this large cardiac impression, which is there to receive the heart. This impression accommodates mostly the left ventricle of the heart. Again, in your fixed lungs, you may find grooves left behind from structures that were neighboring the left lung. If you do find impressions, they will be impressions of the aortic arch and potentially an impression of the descending thoracic aorta as well. And just a reminder, the lingula is the tongue-like projection of the superior lobe of the left lung that comes off at the base of the cardiac notch, shown here. Now let's take a look at the tracheobronchial tree. The trunk of this inverted tree represents the trachea, which courses through the superior mediastinum. Recall that the trachea bifurcates at the level of the transverse thoracic plane, abbreviated TTP. The trachea will bifurcate into two bronchi, called the right and left main stem bronchus, or also called primary bronchi. The main stem bronchi, shown in green, will then divide into the lobar bronchi, shown in purple, which are also called secondary bronchi. And those secondary bronchi divide even further into tertiary bronchi, also referred to as segmental bronchi, shown here in red and even in white as well. Beginning at the first tracheal ring shown here, the walls of the airway are supported by horseshoe-shaped rings of hyaline cartilage in order to keep the airway patent so that the airway does not collapse onto itself. The trachea in general is going to extend from the level of C6, this is the level of the C6 vertebra, down to the carina, where it splits into the two main stem bronchi. The carina is an internal ridge at the bifurcation of the two main stem bronchi. Forming the trachea's posterior wall is a band of smooth muscle that spans between the free margins of the tracheal rings. This smooth muscle is referred to as the trachealis muscle, and this muscle has dual function. It narrows the diameter of the lumen of the trachea during coughing, which helps to increase the force and flow of air through the trachea in order to aid in the expulsion of tracheal contents, whether those contents are mucus or an aspirated object, for example. And secondly, because the trachea sits just anterior to the esophagus, which I'll draw in here, because of this relationship, the trachealis muscle allows the esophagus to expand anteriorly into the trachea partly to accommodate larger boluses of food as that food is being transmitted through the superior mediastinum. So that's the second function of the trachealis muscle. It allows the esophagus to expand anteriorly as it needs to. In looking at the bronchi, you'll notice that the right main stem bronchus, shown here by the X, is wider in diameter, is shorter, and is more vertically oriented than the left main stem bronchus. Conversely, the left main stem bronchus is more horizontally oriented and is much longer because it has to pass underneath of the aortic arch and in front of the esophagus to reach the left lung. The characteristics of the right main stem bronchus make it more susceptible to receiving aspirated objects. To aspirate means to draw in by suction. Let's suppose a small child inhales a nut while eating a caramel apple. The doctor is likely to find that nut in the secondary bronchus of the inferior lobe of the right lung. To fish out an aspirated object requires bronchoscopy. Upon advancing the bronchoscope down the trachea, the carina serves as an important landmark. This is the internal ridge at the bifurcation of the left and right main bronchi. Again, notice from this perspective of the bronchoscope that the right main bronchus is larger in diameter and is more vertically oriented than is the left main bronchus. Each lung also has segmental, also called tertiary bronchi, which make up the bronchopulmonary segments. The key point that I want you to recognize is that bronchopulmonary segments are the smallest segments of the lung that can be surgically resected without having to remove an entire lobe or an entire lung. And by the way, the removal of an entire lung is referred to as a pneumonectomy. The removal of a lobe of a lung is referred to as a lobectomy, and the removal of a segment of the lung is referred to as a segmentectomy. This slide outlines the bronchopulmonary segments and their distribution throughout the lungs. Here's the good news. We're not going to hold you responsible for the bronchopulmonary segments. That means you will not see these segments on the practical exam or on the written exam. Simply use this slide for future reference. Another important skill as a physician is being able to auscultate the lobes of the lungs. So let's take a look at the right lung first. If you place the bell of the stethoscope in the second intercostal space in the midclavicular line, that will allow you to auscultate the upper lobe of the right lung. The fourth intercostal space adjacent to the nipple is a prime location for auscultating the middle lobe of the right lung. And thirdly, the sixth intercostal space closer to the mid-axillary line would allow you to listen to the sounds of the inferior lobe of the right lung. Notice from this posterior viewpoint of the right lung that you cannot auscultate the middle lobe of the right lung from a posterior perspective. That can only be auscultated from the anterior perspective. The second and sixth intercostal spaces can also be used to auscultate the left lung in order to hear the upper and inferior lobes respectively. Do recognize clinically that different regions of the respiratory tree are going to produce very characteristic sounds. Here I've listed three very common sounds: rhonchus, which is caused by obstruction in the central airway, wheezing, which is a very high-pitched sound from obstruction of the bronchioles, and crackles, which kind of sounds like the popping of your Rice Krispies due to alveoli and terminal bronchioles popping as a result of either pneumonia, bronchitis, or pulmonary fibrosis. Because it's a little challenging to describe what these sounds are like, I provided a link for you here to listen to these sounds directly. I hope you'll take a look at this link. Because of the high prevalence of lung cancer, it is useful to understand the lymphatic drainage of the lungs. As you know, lymphatics are often a pathway by which cancer spreads. Let's start with the bronchopulmonary nodes, which are encircled in purple. These nodes live at the hilum of the lung, and you might find some of these in the laboratory as you look at the cross-section of the root of the lung. The bronchopulmonary nodes are responsible for draining the parenchyma of the lung itself. From there, the lymphatics are carried to the tracheobronchial nodes, which are found at the area of transition between the trachea and the bronchi, the main stem bronchi. These nodes are encircled in light blue. Notice how there is a grouping of the tracheobronchial nodes here underneath the carina. This is clinically relevant because if these nodes are enlarged, it could actually demonstrate a flattening of the carina internally when looking at the carina from the viewpoint of a bronchoscope. The next nodes in the chain to receive lymphatic drainage are the paratracheal nodes encircled in orange. These nodes run right along the sides of the trachea. The paratracheal nodes will then drain into the bronchomediastinal trunks, which then drain into either the thoracic duct, which you now know empties into the left venous angle, or on the right side it will drain into the right lymphatic duct, which enters the circulatory system at the right venous angle. Thanks for listening. If you have questions, don't hesitate to contact me. Until next time, take care.